Stewart. I'm Director of Marketing for Main Street Family Urgent Care.
And I'm Rachel Hart, and I am transitioning from education to computer programming. So, quite a big change. So as Team 1, we ended up being tasked with trying to find a solution for a very big issue. How to encourage patients, Medicaid patients specifically, to start utilizing primary care physicians, PMPs, more instead of going to the emergency department. And so what we ended up doing is we decided to look at existing services and try and utilize those that would end up having a high impact reduction in those emergency department visits. So go ahead, Patrick.
Well, to start off, who here has heard about Health Home, part of the ACA? Okay, great. So what we're saying is the problem statement we've come with is the Medicaid patients are not utilizing their primary care doctors due to issues of convenience, accessibility, low health literacy, or simply not liking their assigned provider. A subset of this Medicaid population are eligible for further coordinated care through health home networks, which are not being fully used. So who is our Medicaid patient that we want to target? The chronically ill, the high cost, high need patients. These are the most frequent users of the ED, and they are usually health illiterate. Alright, and to define a health home, the Affordable Care Act, Section 2703, created the optional Medicaid state plan benefit for states to establish the health homes to coordinate care for people with Medicaid who have chronic conditions. Their primary objective is to coordinate through primary acute, behavioral health, and long-term services and support the whole person across the continuum of care, the whole lifespan. So this is the 5 regions of Alabama that the RCO has established. The RCO is in flux, but health homes are not. Commissioner Azar, even if the RCOs do not go through, she would like the health homes. They've been proven as viable, and she would like them to move forward. Other states have shown viability. In Alabama, there's a health home in all 5 regions that are operating. They've all been operating since April 1st, 2015. They're viable. The goal is the program. Overall, improving health outcomes of Alabama Medicaid patients and empowering patients to self-manage their conditions. The doctors can't go home with the patient every day and every night, but if we can empower the patient, empower their family members, the people that are under the same roof of them, to take care of that patient and support their family member of what they need to do to care for their health, be the best family member they can be, and overall reduce the cost of care. How are we carrying this out? So health homes are primary care physician sponsoring. There's also embedded mental health professionals, social workers. These mental health and social workers will go to homes. They'll help coordinate you to the doctor, like rides to the doctor, rides to your primary care physician, and pharmacists. This is big. They will do med reconciliations. What this looks like in practice is they will go to your house. You go to your kitchen table, patient dumps out all their meds on the table. They pick out the ones that are redundant, the ones that interfere with each other, drug interactions, bad, they need to be separated. So take a patient from having 10 prescriptions to 4, that's a lot easier to manage. And for these patients, they're overwhelmed. What does this prescription do? These brand names, what do they mean? It's very confusing. So if you can get a pharmacist to get in there in the house and say, these are the core prescriptions you need to take, and do not take these together because you are going to hurt yourself. CMS guidelines. To be eligible, you need to have 2 or more chronic conditions, have 1 be a risk of a second, or have a persistent mental health condition. So these are the health home qualifying conditions. These usually come in pairs. If you're obese, you might have diabetes. You usually don't get 1 chronic condition in one. They come in pairs. They come in 3s, 4s, 5s. So a lot of patients that are in the state Medicaid program, they are eligible for these health homes. Services offered. So there's a lot on the slide, but the ones that really draw out to me is the coordinator. So the prevention, detection, screening, treatment coordinator. Get your annual screenings, get your flu shots. Other one, the embedded social worker. That's huge. If you get an embedded social worker, they're assigned to a family. If that family knows, they can email that social worker. That social worker knows where they live, their family, family members. If the patient isn't answering their phone, call their sister. Who's the advocate in the house that can really push that patient to take their meds? Make sure they go to the PC. Make sure they're going to their PCP. Funding incentives. Okay, this is already being funded. Right now, it's 90-10 money. For every $1 Alabama's sending up, they're drawing down $9 for every $1. It's just 90-10 money. This stays for the first 8 quarters. In Region E and Mobile, they're already to the 70-30 money because they've been 2 years of operation. 70-30 money is still a good deal. This is an enhanced federal match. And how do you incentivize the primary care physicians? So they're going to get paid $850 per month per member. That's $102 per life per year. 102. Most primary care physicians have around 500 enrollees in their health home. That's $51,000. That moves the needle. That's real money to a primary care physician. They're not going to scoff at $51,000. And again, this money on top of the fee-for-service. When a patient comes in, they're still getting their fee-for-service. They're still billing that code. But they're getting $51,000 just to have them in their health home and watch them over the continuum. Does it work? It does in Missouri, New York, and Washington. Alabama's data is still coming in, but from my knowledge in Region E, it's gone really well. They're seeing patients, they're buying in, they like the social worker, they like the pharmacist, they like the embedded professionals. They feel like someone cares. It's not they're going to a primary care physician once every 6 months, they don't know their name. We're talking about people that personally know the patients and they're really liking it. And the number that really draws up to me is, so invest $8.50 for a mental health patient, save $76.33. That's a good return on investment right there.
So, as Patrick said, we've got a viable option that's in effect. It's operating in all regions. The question we had to ask is, why is this not more widespread? Why is the Medicaid agency not shouting it from the rooftops that these high-need, high-risk patients who are really eating about 45% of Medicaid expenditures, why are we not trying to enroll all 250,000 eligible into this health home program? So we took to the internet, right, to find out more about it. And this is what we found. This is the Medicaid agency's flyer to advertise health home. And, from a communication piece, from a design standpoint, when you're talking about the audience who's receiving this flyer, a lot of times they are health illiterate, and a lot of times that comes with a lot of socioeconomic problems, including regular literacy issues. Maybe English is not their native language, and this is only in English on the website. So if you're really trying to communicate something with your target audience, I'm just not sure that this is really doing it. But hey, down here we've got a link for more information. Click the following link, right? That's the link. That's literally what comes up when you click on that link. So at that point, that's not information. But surely the Medicaid agency is using social media, right? Facebook's a huge network connecting people, businesses. At this point, you actually check in for safety during national emergencies, right? So surely with 900,000 recipients of Medicaid, they're using free social media to push out messages and educate patients. So if we look at their news feed, they posted on November 4th of last year. It's been a whole year since they've posted anything. And what I love more is that the post underneath that is dated from 2013. This is free advertising, right? So why aren't they utilizing it, and how do we remedy that? Really what we have recommended is an aggressive education program, which includes educating providers on these initiatives, educating the patients on the resources they have, and overall altering their behaviors through really focused, targeted ad campaigns towards this narrow percent of these high-risk, high-need patients, and kind of changing their behaviors through emotional appeal, through logic appeal, and advertising the convenience of other services. So first component is the provider piece. Obviously that primary care provider, we want to encourage them to go to them. So that primary care provider needs to be able to speak to the health home initiative. They need to be able to identify which patients are eligible and how they can get them connected in the system. The next step is an aggressive patient engagement system. So really when a patient goes to enroll in Medicaid, there's really little to no education program that comes with it. It's just, here you go, here's your primary care provider, have at it. So what we really feel like is needed is before they're even enrolled, having that eligibility counselor sit with them and not just hand them a giant stack of paper that says, here's the outline of your coverage and here's what you get. Can we create some videos? Can we create something engaging? Again, using a medium, using a targeted message that's really going to actually resonate with the audience you're speaking to. Also, once they get enrolled, there are agencies all around to kind of help with these sort of issues. Can they go through that welcome packet and say, here's your primary care provider, for them, or giving that patient the option, or having them feel like they have a choice, right? And how they get their health care, or who they get their health care from. And lastly, we've talked about some sort of rewards program, right? We want to encourage the good behavior, encourage them to go back to their primary care physician. So there's a lot of ways you could kind of gamify that, or you could really say, overall will reduce your co-pays as you continue to go to your primary care. But what we all kind of talked about was when they first enroll, that first step to that program needs to be that they've got to go to that primary care physician and get an evaluation. Not only will that kind of give us a base of where their health is, but it also gives that provider the opportunity to recognize those health patients. The third piece would be just, again, other tools. Utilizing communication tools you have, your website, hopefully going from the page not found to this, to their lovely website they have, updating that Facebook page. Also down the road, using an app. There are, even with lower socioeconomic backgrounds, they still have access to mobile technology and to internet. The ACA actually provides a program that can provide you with a cell phone, if that's the case. So looking into apps that can connect you with resources like after-hours care, telehealth services, as well as non-emergency transportation. Can it call you an Uber? That would be great. On top of that, we talk about appealing to those patients, right? And kind of doing a campaign to educate them or to kind of persuade them against going to that ED. So not only would we do some sort of regular targeted ads through what I've jokingly called the shame campaign, whereas if a Medicaid patient's going to the ED for one of those ambulatory sensitive conditions that doesn't need to be there, essentially they're taking away from somebody else's severe care. So not as harshly, of course the ad wouldn't be as harsh as this, but along the sentiment of if you're being treated for a non-emergency, you're essentially hurting someone else's grandmother. You're hurting, your mom or somebody else's child because you're taking away time from those physicians. Of course, not everybody has access to mobile technology or internet, so there does have to be a way to hit people where they are. We have to go into communities and meet them where they're at. So they're going to be at their local pharmacy refilling their prescription every month, and they're also going to be at Walmart grocery shopping, or likely cashing a check at the beginning of the month. Go there and have targeted ads in these retail areas at these point of sales. Before they can pick up their prescription, do they have to watch a minute video that educates them on the new Medicaid process? And then ultimately reaching out through grassroots events, using community partners, community resource centers to, again, further educate patients on the resources that they have in these health homes.
My name is Wesley, again, software developer. To bring this home, we're talking about a subset of Medicaid patients. We're talking about 13 chronic conditions these folks can have to apply for this. So it's not going to solve the broad problem, but these are frequent flyers. These are the folks that show up time and time again in the ER. Last night, we called this guy, we got the CEO of the Gulf Coast RCO on the phone for an hour. The guy was eating his dinner. He was nice enough, he spoke to us, he gave us a ton of information. He told us a story about a guy that had been in the ER 13 times, and I don't remember how many months, but it was a very short order. He had spoken to the physician, he was a friend of the physician, had a conversation with him and said, well, why aren't you introducing him to this health home? Had no clue what it was, never heard of it, didn't know anything about the program. He informed him, got this guy going, and now he's not hitting the ER for every visit. He had a lot of these chronic conditions. It's a real thing, it's federally funded, it's ready to go. Nobody knows about this thing. The knowledge is simply not widespread. So how do we keep it in front of people in a permanent way? Let's talk about that. So we talked about Medicaid. You can get a phone if you're on Medicaid, right? Not everybody's going to have a phone for whatever reason. Maybe they don't have signal, maybe who knows what. So we need to have multiple avenues to get through these people. Last night again, learning from the Gulf Coast guys, the cool thing is no matter where you go for treatment throughout the state, your information goes to one place, and that's the claims billing application for Medicare. It's called a Remedy acronym. But essentially the DBMS that houses all their information. So what we're proposing as part of it is kind of a batch follow-up. All we'll need from that system is names, addresses, email addresses, telephone numbers. Go ahead and switch if you would. And then you come up with a really short stack of what you need to do. So using Remedy as your DBMS, there's a host of things you could do. Scratching all this out, you can use a local company like MailSouth. I think everybody knows this, familiar with them. You can hand them this information, addresses, email addresses, text, and say, hey, take care of this for me. But if you're on a dime, you can develop your own. I've done this before. You can develop a .NET console app, host it in a HIPAA compliant place, Azure, Amazon Web Service, wherever you want to put it, as long as it's HIPAA compliant, and then you can go through and handle your mass emails. Everybody knows how to handle that. We could use APIs to handle text messages. The snail mail, I found, again, APIs that will allow you to hand off documents. You can even choose the paper you want, whatever you want, and they'll send out those mails for you. This is something that we can automate. It can run every 6 months and send a notification to folks saying, hey, you're a potential enrollee for this program. This applies to you. And just keep it in front of people. Right now, you can't even go on the web and find any of this information. If you try, it's buried in who knows how much ACA stuff. We found a small little paragraph in the ACA that references that. And if you need this program, you're just not going to find it on your own. So let's talk about other ways that you can find it that we're driving toward. We've had a lot of conversations, and for long-term messaging, we feel the website as it stands is fine. Don't touch the Medicare website. There's probably a lot of red tape, but what we need is an additional website. It's something that's SEO-driven. In particular, a video-driven website with imagery that matches what you're trying to convey. If you switch, if you localize it to Spanish, don't just localize it to Spanish. Switch out the imagery. They should see familiar faces when they go. They should not be intimidating. Every page, each of those 13 chronic conditions should have its own page for SEO reasons. So if I'm on Medicaid and I look up HIV, for instance, this should come up. This should be one of my options that I look at. Maybe I can apply for it, maybe not. But I should see this at some level and know it's available. Right now, not the case. You Google it, you're going to get page broken. Good luck digging around. Another option is we talked about proximity maps, so you can find emergency care, after hours things. And going forward, there's the option of things like mobile apps. And we talked about there's a 24/7 emergency number, which apparently no one, again, knows about for telemedicine. You can call up, you can get a social worker, and they'll help you walk through where you should go, what you should do, 24/7. Again, not easy information to find. We found it, but it took a lot of digging. If somebody's in an emergency situation, they need that quicker. The mobile app can take care of telemedicine. We've also talked about in the future that the state of Alabama is working toward things like Skype, so you could actually see the person you're talking to. Not there yet, but an app would fulfill something like that. It would direct you to after hours care, and something we've talked about is a big issue with these folks is emergency transportation. If you don't have a car and you're relying on someone down the street who's just not home to get you there, there's been a lot of discussion around the Uber for emergency transportation. As that becomes more of a reality, this app would serve as a permanent fixture that could link into something like that for this community.
So while it can easily get lost in some of the tech speak, really what it's going to allow us to do is to disseminate a large amount of information to a large population while remaining cost effective. And ultimately, we feel like an aggressive education campaign will really help promote the services that are already existing within the Medicaid agency and really more efficiently deliver care to those who are in need. Appreciate your time, and we'll be taking any questions.
So you talked about incentivizing patient participation. Talk a little bit more about that. What do you do?
Absolutely. So that is something that, as a team, we kind of went back and forth on how to design that program. I think with incentives and with gifts or any sort of reimbursement, you have to be very careful with legal issues there. Really, what we were kind of thinking along the lines of is almost like a rewards card, or a loyalty membership. And so the more, if you have these allotted visits each year with your primary care doctor, why not take advantage of all those? Why not get some sort of incentive of a decreased copay as time is you increase your visits to your primary care, or however many years you go without an ED visit, having some sort of incentive that way. So it was a difficult task for us to define, and I think that's something that could use more work. But absolutely, I think it could start with getting that patient introduced to that primary care provider who they're assigned to.
How many customers do you have for this product?
In the region, so in Region E, there's a health home, and there's around 30,000 participants. There's 100,000 Medicaid patients and 30,000 participating.
And Medicaid site says that for all the state, 205,000 are eligible for this program.
I'm not talking about users, I'm talking about customers. How many
shopping too. We're talking about interaction between the providers and Medicaid. Both have incentives. One on one side, because you've got ER visits, you know, that shouldn't occur and are interruptive of real emergencies. And on the other side, you've got funds that if you don't use them, you're probably going to lose them. And the Alabama legislature's already deciding on some things on that. But this is federal money. They match, it's 90-10 right now. So really the customers, per se, are going to be providers and Medicaid itself. So we're talking about a limited group.
There's patient-centered medical homes which are similar and they're broader. Health homes are only, it's just from under the ACA, it's only for Medicaid patients. And there's applications that go to the commissioner, the state Medicaid agency, and they have to be approved. They're similar to patient-centered medical homes, but these are Medicaid specific.
So I'm just trying to picture this. You read this, everybody's excited. What's your name? You package this, you go to a medical home and say, well, I've got this cool marketing campaign for you, and your doors are going to be, you're going to be overcrowded from tomorrow. How do you think they're going to respond to that?
Well, step one, I think, is to go to the people that are having problems. And lo and behold, if Brookwood Medical isn't here talking about the litany of issues that they're having, if you can quantify the loss, and that's important to quantify, of someone coming in the emergency room that's got a chronic condition, per se, or would be eligible for this group, quantifying that loss is important, and what we could do to offset that. The other thing comes from Medicaid, and I think that's the great thing about this. There's very few conversations that have to happen. Now, a lot of red tape. I'm not going to sit here and say that Medicaid doesn't have red tape, but it's one database. Once you get that export, you're golden. And then you work with Medicaid and the providers on the income stream to support it long term. What we're talking about doing is not bending the spoon. It's not this massive expense, but it's something permanent that can help out a lot of people.
The point I'm trying to make is it's not easy, and we've had this discussion today. This Medicaid, they jump all over this and have no market. Providers don't assume they're going to be very excited about this because they're getting paid on a per capita basis. And you were saying, well, I'm going to have people streaming through your doors 24 hours a day.
But if you're getting paid $850 per head per month, there's a little bit of incentive for physicians. I mean, we went through that the physicians do have incentive to take Medicaid patients. In the Gulf Coast region alone, it was what, 500 average per.
Yeah, so each health home, which is a primary care physician through all the 7 counties of Region E, average is 500 enrolled.
Check the data on how you use the market insurance that people access.
Right, it's tough. Medicaid sometimes reimburses below cost, and a lot of primary care physicians take Medicaid patients because they think it's the right thing to do. They don't take them. No one else is. They don't love being reimbursed below. They'd rather take all Blue Cross patients, but the reality is they think it's the right thing to do. In some of these rural markets, it's self-pay, no pay, or Medicaid, and you'll take Medicaid before you'll take no pay.
I have a dumb question.
Okay.
Health homes are new to me. I'm not a care person on this panel. It's not the person's home.
It's not a physical building, yes.
Okay.
So that was something I should have said earlier. So it's a network. It is using existing facilities, existing primary care physicians' offices. There is some mobile aspect in that the pharmacy and the social workers will be driving to the home, but it is not. It's not a nursing home. We're not throwing people in a house in a home, locking them up, and saying stay healthy. They're living in their own houses. They're living their daily lives, but they participate in this health home network. Not even the home is like the social worker. They want someone to know their name. They want to be involved in this health home. And we talked about making the patient want to be part of the home. That's important. But you have to draw them in, show them the importance of managing their chronic conditions and the importance of, as a group in this home, you can succeed.
And so these health homes are underutilized. You know, this is your whole premise.
Yes.
Right.
Can you give us some indication of what success looks like? Like, hey, if we had $10 million to do a marketing budget, then we think we could get X number of patients utilizing health homes and save the entire process $100 million.
So I know the slide that I presented, I kind of glazed over it. Go back to
Back one.
this. So Missouri, New York, Washington, part of the ACA, any state can do this, or and operate these health homes. So when we're talking about real numbers, you're asking about we're talking about marketing.
Well, you're
marketing
going to spend a bunch of money to better market their availability. Like, how much do you need to spend, and what's the result? What would be
Right.
a
Well,
successful
first,
result?
Facebook's free, so I think they should get a hold of their Facebook site. But I think Medicaid has. So we're talking they're funded at $700 million right now. They can take away some other portions and allocate towards marketing. I think the front end investment of marketing of a health home greatly has a great return on investment for Medicaid agency.
Can I jump in here just for a second?
No, I'm sorry.